Good evening, everybody. Thank you for joining us. We are going to start momentarily. Thank you. Good evening, everybody, and welcome and thank you for joining tonight's informational webinar on the CF and COVID-19 vaccine. I'd like to take this opportunity to thank tonight's sponsors for helping us bring this webinar to you and the CF community. Thank you to Vertex, Viatris, Gilead Sciences, Nestle Health Sciences, and Optum Specialty Pharmacy. I just need to begin with a few general announcements. Just want to let you know this webinar is for informational purposes only, and medical information discussed is general knowledge for the CF community. For case-specific questions, please consult with your personal CF care team. This webinar is also, it's being pre-recorded and can be seen on the video page of our website at www.takeabreatherfromcf.org. We will have a Q&A session towards the end of the webinar, so you can ask questions. You see the Q&A icon at the bottom of your screen. You can go there to answer your questions. My name is Matt McCluskey, and I'm the Executive Director of the Take a Breather Foundation. And I would like to welcome and introduce our esteemed panelists and thank them for giving us their valuable time this evening. With us is Dr. Denis Hadjiliadis and Dr. Dan Dorgan. They are my personal care physicians, and they are from the Hospital of University of Pennsylvania, the Adult CF Center. And I would like to welcome Dr. Dorgan and Dr. Hadjiliadis, and again, thank them for taking this time to answer and tell us about what's going on with the vaccine. There's a lot of people out there, I know, in the CF community that are, looking for this information. So we figure it'd be great to go directly to the source. So I'm going to turn it over to them now and get started, and then we'll move on to the Q&A session. Dan and Denis, it's all yours.
Thank you, Matt, and thank you for inviting us, and thank you for all the work you do at Take a Breather.
Thank you.
Dan, you want to say a few words too?
Yeah, thanks for inviting us to give this talk. It's an important topic, and we're happy to be here to answer some questions from people.
So I'm going to start with a few slides, but the idea behind it here is not to present you too much data. It's more, just to put, things into perspective and give you an opportunity to ask questions. I think everybody knows that by now. This is how coronavirus look. That's when it started. And I have a few, slides just for comparison. So the last time we did the webinar, that's how many cases we had worldwide. And the red spots were not, as many. That's how the United States was at the time, 203,000 cases. This is what it is now, based on a screenshot that I got from, Take a Breather, not from the Johns Hopkins website, which has a lot of cases, and most of the counties by population have a lot of cases. And this is how the world looks right now. And all those areas are fully red. So I don't need to tell you much about this, but I think everybody knows it has affected the majority of the world, maybe with the exception of sub-Saharan Africa, which has had a fewer cases, and maybe Australia and New Zealand because they're far away. What we know so far is that the most important probably determinant of poor outcome is being old. So you can see on the right-hand side that if you're, in the older, age group, you have much higher, mortality compared that if you're younger. Men are slightly higher than women. And this is a study for Medicare, so it doesn't apply completely, to CF, obviously, because not many Medicare patients have, cystic fibrosis. But in general, again, the same is true. Older patients, do worse. And if you have chronic conditions, you tend to do, worse. And probably the biggest, surrogate that we have for cystic fibrosis is having COPD or some chronic lung disease, which shows that it increases your risks. Any comments on that, Dan?
Yeah, I would say, at least in terms of CF-specific statistics, we do have, the CF Foundation sends out weekly emails with the stats. Do you have that in an upcoming slide?
That's there. That's the next one. Can you see it, Dan?
Yeah.
Yep. So
yeah, go ahead.
This is from last week. So according to the Cystic Fibrosis Foundation, there have been 529 cases that have been confirmed, majority in adults, 204 in kids. Total is 733. So this is basically less than 3%. It's probably closer to about 2% of the CF population, which is actually lower than what we have in the US population. Like in the US population, we have probably, based on the confirmed cases, over 20 million cases. So that's about 7%. And you can see that there is hospitalizations mostly in adults. It's basically 80 out of, 529. So it's not 20% exactly, but it's about 15%. And pediatrics about 10%. And thank God, much, less devastating than we expected. Unfortunately, we've lost 3 people according to this data to the COVID-19. The deaths were more common in the transplant, population as expected. So we have 2 out of 44, but even in people with advanced lung disease, 1 out of 53. Dan, if you want to say anything, go ahead.
Yeah, I think with this data, I think the one thing this is where the people with CF are to some degree protected by age. That we were really terrified in the spring that this was going to be devastating for the CF community, and I think what we're seeing is that just having younger demographics on average helps. Now, of course, for an individual, the average is not what matters. It matters what happens to you as an individual.
And I'm going to add to that also. I think our population, patients with CF, are excellent about protecting themselves, wearing masks, cleaning, things, staying away when necessary. So there probably are pros in all the things that everybody else had to learn in a very specific way. So this is another study. That's a global study of CF and COVID illness. The data is only until June 13th. So it takes time, to collect it and publish it. And it was published in October of 2020. It had 19 countries, and it had 7 deaths, 3 in transplant, 4 in non-transplant patients. And what you're going to see here is that post-transplant is relatively overrepresented, like in the previous slide, but about 1 in 6 patients that got the disease was, transplant related. And that was, one of the major, factors. And of course, they had more diabetes, they had more other, things. And in general, their lung function was better than the other group. And then when they looked, at the different outcomes, transplant, was a lot more significant in, leading to, the different, effects. So you can see here that hospitalized patients tended to have, more lower, FEV1 than the ones that didn't. The ones that needed oxygen, they had worse, FEV1. The ones that needed ICU care, they were all, worse if you had worse disease as expected. And then if you looked, at before, before and after, transplant, things were, a little worse for the transplant population. So there were, more people in the total that, were hospitalized if they had already a transplant or needed ICU care or other things. One of the things that is noticeable is it appears, with 7, mortalities that they had in that number of population, either because, this was earlier in the stage, of the pandemic, and they had fewer, testing. It's quite possible that maybe they picked up only the more severe cases, or the other possibility is maybe the US population, which is with the data that we have from the CF Foundation, is more protected because we've had more, Trikafta, more elexacaftor, tezacaftor, ivacaftor, all those medications have been approved, in the US for a longer period of time. So we don't know if that plays effect, but I would like to hear your thoughts, Dan, too.
Yeah, it's hard to say because I think even for what we've seen, even with patients who are not, whose mutations don't qualify for the CFTR modulators, overall, it seems like we've seen similar outcomes, although we don't, but that's more anecdotal. We don't have data on that. I have to say, one thing I've been saying and counting our blessings in the past year is, thank goodness this came a few months after Trikafta was approved rather than a year before. Maybe it wouldn't have made a difference, but I think it provides a lot of peace of mind that people are on average doing much better on Trikafta than they were before.
Just to ground you, a little more, I'm going to move, a little bit on how this is, infectious, this is. This is, a lot of different, infections from before. And in the spring, we kind of knew this is where is in the infectivity, basically, average number of people infected from every, sick person. And the fatality, how many people, that get the infection, die of, the new virus. So I put, blue. This is where we were in the spring. So we didn't know if the mortality could be as high as 2 or 3 or 10%, or as low as 0.1. It appears to be somewhere between, probably 0.2 and 0.5 or 0.5 and 1, based on, the best studies that we have. In the population that's reported, it's a little higher, but this is skewed in some ways, and how fast it spreads. So it appears to be, a lot, more effective in, spreading than the flu, less deadly than SARS or MERS, spreads less than the measles, basically. This is just to ground us and put it, from before, compare it to before. I think you've seen this slide multiple times, so I'm not going to, basically go through, with it. So I'm going to bypass it right now. Next, I'm going to, basically go over a little bit about the vaccines. Since we're talking about vaccines, I have a couple of, tables that took out from a report, but unfortunately I couldn't get it on a PDF, so they're not, very nicely, done, and they don't look, very well. But this is all kinds of different, diseases for which, we've had, the first vaccines at different times. So smallpox, it's here. There was not, a vaccine with a modern, way, but in the 1790s, they started having ways of, basically being able to immunize people, against this. And then you can see typhoid, cholera, diphtheria, all kinds of different, things that we got, vaccinations, for. Polio is somewhere, in here, and a lot of other, basically vaccines. On the other side, in table 2 from this report, you're going to find out what the baseline annual morbidity was in the early part of the 20th century and how it became at the end of the 20th century. So you can see that smallpox went from 48,000 cases to 0. Polio went from, high number of cases to very, very low, almost 100% reduction. Same is true for diphtheria. Pertussis went down, tetanus went down. So for a lot of us that are, younger, and a lot of you that are, even younger, than some of us, all those diseases were diseases that our parents and grandparents were fearful of. And they're really worried that it might make a big difference. And many of them have disappeared because of vaccines. So this is, for people, that don't remember them. This is an important aspect to remember, that even, 2 generations, before, those are, devastating diseases. Dan, anything to add on this? Anything to say?
I don't think so.
So a little bit also about vaccine skepticism. Why am I telling you, those things right now? Because a lot of people are going to start, with this and tell you about all the bad, things. So the most common skepticism comes from a recent vaccine, or relatively recent now, but it's about a little over almost 50 years ago. So there was fear that in 1976 there was, the Spanish, flu is going to come back and kill a lot of people. So they started vaccinating a lot of people. They vaccinated in a very, very rush way 45 million people. And within 6 weeks, about 450 people developed Guillain-Barré syndrome. That's a syndrome where people develop mostly reversible, but pretty paralysis, but it's pretty severe, disease to get that, to suddenly be paralyzed and then, wait for, weeks to months to get, back to where you were before. So this created, a lot of, bad press. And obviously at that time, people were vaccinated hastily for a disease that didn't end up killing, as many people, which is not, the same situation that we have right now, when we have already, quite a, millions, of deaths worldwide from this. And this is, raving for like a long time. But to put things into perspective, you have about 1 in, 100,000 people getting, a significant, problem. But at the same time, every year in the US, you have anywhere between 12 and 60,000 people that die from the flu, irrespective of everything else. We also know that if you get, for example, the flu shot, and every year, other than that year, we don't have, this complication, those, numbers, the cases, ICU admissions can, reduce, by 50%. So that gives you a little bit of a perspective where, a lot of the anti-vax and skepticism movement comes from. But even in those numbers, still, they are minute and very, very low. Let me know if you have any thoughts or anything on this.
No, I think the other piece of vaccine skepticism that comes up is from Andrew Wakefield's work in the late 1990s, which not only was debunked, it was proven to be actual fraud. So the claims of autism connected to vaccines were, and I think a lot of people don't even capture that it's not just that it was wrong, it was actually like fraudulent behavior that was completely unethical, made up data that was published, and it was only caught after the fact. So a lot of the objections people have to vaccines are based on lies, essentially.
Thank you, Dan. And I didn't put that in there, but that's very, very important, to remember, because this is even more recent. So this is, a list of vaccines that I got from the Infectious Disease Societies of America. I don't want you to focus on too many, but that gives you an idea how many vaccines are right now in late stage development. Those are, vaccines that might end up, being available in the next, 6 months for a lot of them, or already available. The ones that we're going to talk more about and you're going to hear more about is the one that's number 3, the one that says by BNT162, that's the Pfizer-BioNTech vaccine, and the mRNA 1273 Moderna vaccine. Those are both similar vaccines. They are mRNA vaccines. What does that mean? They take a little piece, which is programmed to make a piece of the virus in somebody's body, so that that instead of the virus can act as an antigen, as an insult, so that your body makes antibodies against that part of the virus. So when it sees the real virus, it's able to fight it. This technique is very new because instead of having an actual piece of the virus or having a dead virus or a weak virus, it actually has just a piece of mRNA, which is a blueprint to how to make a piece of the virus, basically. And it's surrounded by a bunch of lipids, by little fat droplets, so that it's protected and can go to the human cells. This is the first vaccines that have been developed that way and approved. But the technique has been around for a little while. And actually, Dr. Dorgan is a local PI in a large multi-center study, which is now, I think, on the phase 2, and you can tell us a little more, that uses a similar technique to actually correct CFTR in the lungs, not by an injection, by a different way. So this is not novel. You want to say anything to that, Dan?
I think the key thing with this is that when people hear RNA, sometimes people hear that and they're thinking, okay, this is genetic material, and are worried, is this gene therapy? Is this something that's permanent? And I think that the key thing is this is not DNA that's incorporating into somebody's DNA and becoming a permanent change to their cell. That when when our genes are being converted to proteins, in the nucleus of our cells, a copy of DNA is made in messenger RNA, which then leaves the nucleus of the cell, and within the cell is that code is used to make the protein. So essentially, this is using that intermediate step of the messenger RNA to make the protein in the cell. And one really good thing about messenger RNA, well, it depends on your point of view. It's bad from the standpoint of storage and stability. This is part of the reason that this vaccine needs to be kept so cold, is because messenger RNA breaks down really quickly. So, so you can't just put it in a refrigerator; it'll break down before you actually can give somebody the vaccine. But when it's injected into somebody, people are worried about, well, what about long-term effects of this vaccine? And really, we don't have a lot of reason to worry that there would be long-term effects, because the messenger RNA, it breaks down so quickly that it's there long enough to make the protein so your immune system can respond to that protein, and then if it sees the real virus, attack the virus. But it's not leaving behind some product that's staying in your body for an extended time.
That's a very, very good point. And it's being utilized for patients with CF. Am I correct? That's the same technique essentially, except now it's nebulized, basically giving the mRNA in a nebulized form.
Exactly.
Yeah. The other, vaccines that you hear a lot about is the AstraZeneca vaccine, which uses a weakened, virus as a carrier. So instead of having, the actual, virus that creates, the disease, you put, some of the genetic same material in that virus. You inject, that basically creates an immune response. So when you see the real virus, you can fight it. This technique is also used by the Russian vaccine that you can see over here. And there's a couple of, Chinese, vaccines that are, in there. This one, which we're going to mention a little bit, and there's some news from this one, today. I'm sorry, not this one. It's the one down here, which is basically didn't do as well as expected. I think there were some results that were, reproduced today from Brazil that I don't have on slide, but we can talk about it a little bit. And, the other one that's most interesting for a lot of people is, let me see if I have it, the correct somewhere in here. Where is it? Is it the, there's one vaccine that's one injection. Almost all the other ones, I don't think somehow it made it to this list. Every other one is 2 injections, because most of the times, like for every other vaccine that we have, usually a booster is needed to basically make your immune response really, react, and create, enough of, vaccinations. So I think that's the vaccine from Johnson & Johnson. So what, that does that mean? This is, some results from the Pfizer vaccine. In the blue line, you have the placebo. On the red line, you have the people that got, the vaccine. And it's very easy to know that once you get the second dose, of the vaccine, your curve becomes flat. You don't get symptomatic COVID. And the key thing here is symptomatic COVID, because they didn't test out of, the 20,000 people that they gave vaccine and 20,000 that they gave placebo. They didn't test everybody to see if they had it. But if patients called and said, I'm not feeling well, then they did the testing. So once you got, the second dose of the vaccine, this flattens out almost completely. This side, keeps going, up as expected. And this is, a microcosm of this. And here you have the total number of cases that comes up, to a vaccine efficacy of about 95%. And if you look at the severe cases, the statistical, significance there is a little different, because there's so few, numbers. 9 of them happen in placebo, 1 in the vaccine. So that translates roughly to a 90% efficacy, which is more or less, the same, but with a wide, difference. So basically what it appears is that we have much lower rates of people getting symptomatic, feeling sick at all in any way from COVID if they got the vaccine. And I'm going to, basically show you some side effects, profile, and then the Moderna, and then we can discuss, and I'll have done, say a few more things. So one of the things about, the vaccine, however, is it does cause some, reactions. So here you have, mostly things like, pain and, different, effects that you might have from the vaccine, and the placebo. So for dose 1 and for dose 2, you can see, different, reactions, like mostly, basically here is local events. So I think one of them is, pain for people, that are young, and then pain, localized, things like here is, the pain, redness, and swelling in people that are older. So those are common. And I can tell you myself, I got, the vaccine, and I did feel, more pain than I felt with other vaccines. And here's some systemic symptoms. So fever, fatigue, headache, chills, vomiting, muscle pain, joint pain, and use of any kind of medications to like Tylenol or Advil or Motrin or anything like that to stop the symptoms. So those are not extremely high, but they are high. So you can see like basically close to half the people felt that they had some fatigue. Now the placebo had already a 33% rate of the same thing, and with the second dose this was similar. And some people had a lot of headache, and some people had chills. So this was a relatively common effect. But all of those were, short lasting. Within 24 hours, they were, completely, gone. And it's not like they only happen on the vaccine. You can see that there's a baseline rate of some of those for placebo too. Dan, do you mind if I go to, through the Moderna and then, we can comment on this?
Sure, go ahead.
Yep. So the next, vaccine trial was the Moderna trial. That's the other one that has been in use and approved in the US, and it's almost the same like the previous one. So you can see very quickly, you vaccinate people, you get, the second shot, and 2 weeks later, the placebo keeps going up, and, the new cases, they are going, basically they're flat in the symptomatic cases. And the same thing is true here. There were 30 cases, basically of severe COVID, and they were all in the placebo group. Now that suggests that this one is 100% effective in this, and, the other one is 90%, but those are such a small numbers that you cannot tell the difference. And when they looked at subgroups to find out if it was the old people, the younger people, who was protected, everybody was protected, and it was almost the same across the board. So they had, even higher number of people with effectively the same results. And when you look at their side effects, pretty much, the same. So people, had, any local event, it was pretty common, and it was more common than, on placebo. So you had more arm pain and other things like that in that perspective. And if you go to systemic, events, which was the same like the other ones, you have the placebo people getting quite a few of those, but, the people that got the vaccine did get, more things like a fever, a headache, myalgias, arthralgias, things like that. So very similar profile. I would say that even though the populations might not be completely, the same, and the protocol not completely the same, the results, are very similar, and the idea of the vaccine is very similar. Dan,
just to translate a couple of medical words you threw out there, you said myalgias and arthralgias. So
muscle pain,
muscle pain and joint pain.
Yeah, go for it. Anything else to add on those?
No, I think, I mean, the thing that was, if, when people were asking back in the spring, what do you expect out of vaccine? My thought was, what I was telling people back then was, it'd be great if we get a vaccine soon. We're likely looking at something that's years out. We've never successfully had a coronavirus vaccine for any coronavirus before. Granted, we didn't have as much of a motivation to develop a coronavirus because all the other coronaviruses were common cold. And if I had seen something that was a 60% effective vaccine, I would have said, that's great, let's move forward. When we saw 95%, I mean, I even saw there's a kind of nerdy comic strip called XKCD that they one of their comics recently was showing the graphs of the difference with vaccine versus placebo, and they were saying, pro tip, get data that's so good that you don't even need to run statistics to tell that there's a difference. And I think that that's clear. It was such a dramatic difference that it's like that there's absolutely no question about the effectiveness of these vaccines. It's not something where you have to run some fancy statistics to say, oh yeah, we think it actually is a difference. It was an outstanding remarkable result for both of these vaccines. And we're still waiting, as Dr. Hadjiliadis mentioned, Johnson & Johnson, Novavax, a couple of these other companies have not yet gotten to the point where they can release their data from their vaccines, but they're getting close. I think within the next couple of weeks, one or two of those might be releasing data. So fingers crossed, it'd be great, because the more companies that have successful vaccines, the faster the rollout can happen. Because right now, the limitations are supply and manufacturing and getting the logistics out. So if we can have more successful vaccine, like I'm cheering on every single one of these companies, and hopefully we have more great successes. But at least just having these two is an outstanding start.
Yeah. Thank you for saying that. This is very similar also to people that went on the new CFTR modifiers. We could tell if they were on placebo or not, and they could tell too. Mm-hmm. You didn't need statistics from that. This is the vaccine from AstraZeneca. And the only thing I'm going to mention here, because we don't need to spend too much time on this, they had a small subgroup of patients where they tested actually themselves for COVID on a daily, basis in the UK, part. And what I found out is that the reduction on that group of patients was also, similar. So they only had a 65% or 60% effectiveness, but, it was much less, common severe COVID, 60% symptomatic, COVID, meaning that you felt anything, but also the asymptomatic was reduced by a similar number, which is a very good sign, because that means not only, you have people that might get, the infection, but they don't get sick, you probably have fewer infections too, which is very significant when we think about how to protect the whole population. And other, this is more from press releases. There's one from today, not to say much, but, the Russian vaccine reported 90% efficacy, but a lot fewer cases, and they haven't, published their data, yet. And one of the Chinese companies suggested anywhere between 79 and 86% efficacy, a lot of patients, China, UAE, and Bahrain. And one, the worst news that we got was something that maybe, about 9 months ago, had we got it, as Dr. Dorgan said, we would have got it, was the Sinopharm, I think, that in Brazil had an efficacy of over 50%, but barely on that, with good, effectiveness in preventing severe disease. So what we do not know at this point is, does this, vaccine prevent, infection or only disease? We mentioned it a little bit before, but it's possible that some patients will get, actually infected, but they might not get, sick from it. Does it do it proportionally, which is what we talked about before? Does it prevent 95% of infections like it presents, symptomatic disease? We do not know. How long does the protection last? Is it going to be something that's going to be there a year from now? We know it lasts for at least, 3 to 6 months based on the studies that, have done so far, but is it going to go longer? And do we have, other ways of having immunity, even if we don't have antibodies? Antibodies are good because, we can easily measure them, but T cells are really the quarterback of, the way our immune system, responds. And if you have T cells, you can make antibodies pretty quickly. How about patients with CF? We don't have a lot of data on all this. I think the Moderna said somewhere that they had, some CF patients. However, when I went in, to the data in the supplement, they just put chronic lung disease. They don't say how many. How about transplant patients with CF? Here, we don't have data. The truth is, for transplant population, we don't have. And will new mutations evade the vaccine? A lot. Another question we do not know, the mutation, that came out in the UK recently, there was, a release from Pfizer suggesting that it's okay, but there's some concern, for example, a new mutation might be a little more effective at avoiding, treatment from the vaccine. But what we have to think about is that, the key here is not so much preventing everybody from getting, at all, the infection. The biggest, reason that this, coronavirus is so difficult is because even though it's a small number, it has enough people that end up, in an intensive care unit, and they end up in the hospital, they overwhelm the system, and it creates devastation. If we can decrease, that rate, it's still, basically good enough. Even if it's, somebody getting a sniffle, we can accept that compared to before. Anything to add to those, do not knows before we go to the last slide, I think?
No, because I think a lot of people have questions, so I want to get to people's questions rather than.
And what we do know is that, the vaccines will not make things normal immediately, because mask and precautions will probably continue. We need to see the cases, drop. And, the new technologies, for example, this mRNA, is easy to change the vaccine a little bit if you need to. And, for the vast majority of patients, especially with CF and other chronic diseases, the risk of any, basically vaccine complications is much more likely than not, much lower than any risk of COVID-19. I think that's my last slide, and we can open it up to questions. Matt, you want to take over and ask some of the questions that we have before?
Yeah. Sorry, there we go. Okay. Great. That was all great information. And you're right, Dan, we do have a lot of questions here. So some people had submitted questions prior to tonight. So we will try and get to those. We're going to try and get to everybody's questions, but obviously, we have time constraints, so bear with us. Okay. First question, can a vaccinated person carry the virus and give it to their family members that are not vaccinated?
Yeah, so I think this is something that Denis was getting at in the second to last slide. At this point, we don't have the data to say for sure what happens. So people are erring on the side of caution of just saying, hey, don't be overconfident that after a vaccine you cannot possibly be contagious. However, there was some preliminary data. I believe it was Moderna. I might have that wrong. It might have been Pfizer, but there was some preliminary data suggesting that there was even decreased asymptomatic infections. So, I think it stands to reason that effectiveness of the vaccine would actually decrease how much people are contagious, and that's part of the whole principle we're trying to go for with the idea of herd immunity. That that we want to get enough people immune so that even the people who don't have immunity, because that's the other thing, is you figure a vaccine that's 95% effective, well, that means it's 5% ineffective. And so for that 5% who get vaccinated and are still not protected, it's important to have the community not spreading the virus. So in the end, my take is I would be really surprised if the vaccine fails to protect from spreading it to others. We just don't have the data right now to say that with absolute certainty, though. So I expect it would actually protect you. Getting the vaccine would probably protect your family members. It's just not something we can say with 100% certainty right now.
Okay. Again, if I do repeat a question that you answered, just let me know. Any update on the timeline for vaccine trials for children, or when authorization is expected?
I think that they started already, trials to go, I think I want to say down to the age of 12, if I'm not mistaken. The Pfizer vaccine was also approved for 16 and above. The Moderna was only an 18 and above. But I suspect in the next few months, data will come out, for children, and they're going to be included for some of those, groups, and they're going to go younger and younger. Like you've seen for the CF medications, they usually, get approved for the older, kids, and then they go to the younger as they go, along.
Okay.
Anything that you have on that, Dan? Any information on that?
No, I haven't heard anything more than what you just said.
But I think they started, yeah.
Okay. Will CF clinics be administering the vaccine to CF patients? If so, how will CF centers distribute the vaccine among the patients?
That's a very good question that people are asking all the time. And, we have tried to be proactive in saying that as soon as we know, we will let you know. And even, last week's on the webinar for healthcare providers from the CF Foundation, nobody, knows yet how this is going to, happen. If the CF, clinics distributed, what we will do is going to depend on what we have. So we have enough vaccine for everybody, like for the flu shot. We're going to, try and get everybody in as soon as, possible, and probably communicate with everybody. Obviously, if we have, patients, we will tell, patients, everybody should get it. But, if you're, one of the healthiest ones, okay, it's okay, to wait for, a week, give a chance, to the sicker ones. If we have, basically only limited amount of vaccines, obviously we're going to have to find a way to give it to the people that are the more likely ones to benefit. It's also quite possible that we might not be the ones, administering the vaccine or being so granular in the data. My suspicion is that's too complicated, for systems to do. And part of the reason that we've had a slow rollout on this is I think people try to be, a little too granular and give it, to only this person and not the other person, to this person, not the other person. And I suspect as, more vaccines become, available, it's going to be trying to get as many people as possible from our perspective. Also, some of the US, vaccines, the Moderna and the Pfizer require special, cooling. You cannot waste doses. You have to make sure that everything is done in the appropriate way. So there is a possibility that even if it happens within our health system, it might not be the CF clinic, for example, doing it. It might not even be the pulmonary clinic. There might have been some kind of the same, clinic that vaccinated healthcare providers gets, patients, where they say, okay, it's time for these patients. And we tell our patients, and then they make a schedule and they go, basically. And they can see on the record that they have, basically a disease that qualifies for this. That's my suspicion, but I do not know that information, yet.
I think part of this is these are being widely distributed. A lot of and different states are doing things differently. For example, New Jersey is trying to do big super sites that can process a lot of people in a large space to maintain social distancing while vaccinating a huge number. So, for example, Rowan College is doing a super site, Meadowlands Racetrack. I think they're aiming for about half a dozen total. So far, they've still just, New Jersey's opened it up for healthcare workers, nursing home residents, which is basically everywhere in the country is covering those two groups. New Jersey's also opened it up to firefighters and police officers. Whereas Pennsylvania's right now just at healthcare workers and nursing home residents. But and also just with the rollout, since it's going through individual pharmacies too, I think in the end, what it's going to come down to is where can you get it soonest, and that may vary depending on where you live. And so it makes it hard to communicate a specific plan, because this is just going to be a matter of us figuring out on the fly what options are opening up when and where. Now, one thing in New Jersey, people can actually pre-register saying they want the vaccine, and giving some information about themselves so that they get contacted when their group is up and running. Pennsylvania, I have not seen anything like that, but they do have a central website that also shows here are all the locations that that are currently providing vaccines. What I can do is, Matt, I guess the chat is active, so I can, if I pop some links into the chat, people can see those for different states.
Yeah. Mm-hmm.
Okay, so I'll do that while you're asking the next question.
Okay.
And
This is kind of a follow. Go ahead.
Can I say, something to this? If, the clinics, if, you go somewhere else and they ask you for a letter, we are prepared, to provide something like that. We're going to be, as a clinic, and I'm sure other clinics will do the same, something that says you have a condition that needs it. Okay, so that's, the other part. So it might be that if you go to CVS, you need to show something. So we're prepared, for this.
Okay.
And actually, somebody just, Jennifer Fell popped up in the chat saying that New Jersey on the 15th is opening to pre-existing disease. I had not heard that yet, but that's very, yeah. So I'll
yeah, I think
we'll see if we can verify that.
I think I read some of these comments, and I think something went on today in New Jersey. I think they updated.
Okay. Yeah, I missed that announcement. That's great.
Their information.
And that's
today.
where if you're pre-registered and then you're showing in your pre-registration that you have pre-existing disease, that'll help. And I'm not sure how much they're just taking people's word for it versus saying, oh, you need some documentation. So, and that might be in the announcement too. So we'll try to figure that out, and we can send out follow-up to anybody who signed up for this.
Okay. Will patients 16 and older with CF fall into the newly modified CDC category of 18?
Can you repeat that, Matt?
Yeah. Will patients 16 and older with CF fall into the newly modified CDC category? Oh, sorry, 1B.
I'm not sure that I can answer directly, that question, but the answer, is I would expect anybody that has, a chronic, condition qualifies, under, this. So I'm not sure, I didn't get, the specific, part of this, but I don't see why this would be different.
Okay.
Yeah.
Is there any way for parents and other household members to get priority status for a vaccine based on their child's underlying condition?
I don't think there's anything anywhere that I've seen that suggests that this is, an option right now. It's a good question, and it makes sense. We think of it, in our transplant population, for example, for the flu shot. When we give the flu shot to transplant patients, we know it might or might not work as well. But the other way to protect, that patient is vaccinate everybody around them. And unfortunately, I haven't seen anything that says that we have enough to be, protecting, the caregivers around them. Dan, do you know anything on that, extent?
No, I agree that it would be an important thing to do, but the CDC and the states, I've not seen anybody saying that that's actually the policy that's being implemented, even though I think that would be a good policy to implement.
Okay. What will the COVID-19 vaccination do in relation to antibody levels, especially folks with already high levels?
Yeah, so I think I've seen this question, from before, and it comes from somebody that has pre-existing antibodies for transplant. That's where this comes, from, because I've seen, the person that asked that question. So the question is, does that, rev up your immune system and create, more rejection, or, create, more autoimmunity or something like that? To the best that we know from other vaccinations, this is not, the case. This is not, something that we have to worry, about. It's something that, in the transplant fora came up. Some people, questioned it, but I can tell you that, the vast majority of infectious disease and transplant experts and the evidence that we have suggests that this has, no effect. from that perspective. The main worry that we have about transplant patients, and to the extent that the worry that comes from it is not so much that it will be harmful, it's whether it's going to work the same way, whether it's going to create enough of an immune response to create enough protection. The same is true for the flu shot and a lot of the vaccines. But the vaccines that have been approved and the vaccines that are in development, all of them are either inactive pieces of mRNA, the virus, or a dead virus. Some of the ones in China are dead virus. So there's nothing that should be harmful to any transplant patients from a perspective of an infection.
Okay.
I think that so a couple of people helpfully chimed in on the chat with the links to the New Jersey information. So yeah, it's starting tomorrow. It's individuals 65 and older, and then individuals age 16 to 64 with medical conditions defined by the CDC, increasing the risk for severe illness. Now, interestingly, the only lung condition that's listed under here is COPD. So essentially emphysema, chronic bronchitis. Smoking is also listed. The only thing the other things are cancer, chronic kidney disease, which some patients with cystic fibrosis have, Down syndrome, heart conditions, obesity, sickle cell disease, and type 2 diabetes. Now, again, I think in that situation, somebody with cystic fibrosis related diabetes, even though it's technically not type 2, I think that there's enough overlap there that it may be worth making that argument. But that's the list that's on the New Jersey website. Thank you to those who sent those links in the chat.
So one thing also to say about COPD, technically, COPD is the most common lung disease by far. So the reason probably that it's mentioned is because they cannot mention every lung disease. And obstruction, which is a physiologic impairment, is present in a lot of people that have, not everybody, but a lot of people that have cystic fibrosis. So I don't know.
And Madeline has added on the chat that on the New Jersey pre-registration, CF was listed specifically, which is a good point, that they are asking about that. And I think it still makes sense to register, list yourself as CF. And I think this is a situation where advocating for yourself with this, just because CF is not listed on the on the conditions on the website doesn't mean that it's not worth trying to make the case that it's worth getting the vaccine.
Exactly. And for us, when we write that you have CF, that's an obstructive lung disease. That's how we define it. Okay. So this is semantics, but it's not like technically that you're saying anything different. It's a chronic disease that creates lung disease.
Okay. Will medications like prednisone affect the effectiveness of the vaccine?
Very, very good question. So we kind of mentioned it for transplant, that we expect that transplant patients will have possibly less effectiveness. And that's likely true because just how it is, with every vaccination in a transplant patient. If you're a very low doses of prednisone, it will probably have a minimal effect. And there's a gradation to this, like somewhere, from being 5 milligrams of prednisone a day, which is probably close to having no effect, to being, 20 or 30, which probably will have some effect, to being a transplant recipient, which has more of an effect. So it's probably yes, but not, if you're on very, very low doses of prednisone, probably will have, if any, effect minimal. Dan, any thoughts on that?
Yeah, I agree. We don't have data on how people are responding to these vaccines on prednisone, but I think it makes sense that when you're on a drug that part of the purpose is to dampen your immune response, that your immune response to a vaccine would likely be less robust. We don't have the certain data for that, but I think it's still worth getting the vaccine. It's just you might not be looking at 95% effectiveness in that circumstance.
Got it. Okay. If a person has an anaphylactic reaction to medications, is one vaccine more preferable than the other? Are there any other special precautions they should take before getting the vaccine?
Dan, you want to take this one?
Yeah, so I mean, even with anaphylactic reactions, the rate of anaphylactic reactions has been about 1 in 100,000 people, which is actually similar to the flu vaccine. So, and in general, it is people, for the most part, it's people who've had anaphylactic reactions to other things. In particular, what they think is it might be the polyethylene glycol or polysorbate reactions. And so polyethylene glycol is what's in Miralax. And a lot of people with CF have taken Miralax at some point in their lives. So if you're somebody who has not had a history of severe anaphylactic reactions, then I don't think there's any real reason for particular precautions. Part of it, everybody who gets vaccinated gets monitored afterwards to see if they're having a reaction. And even those who've had reactions, I mean, we're now up to millions of people who have gotten the vaccine. There have been no deaths from it. To my knowledge, there's not even been anybody in the ICU for it. There have been a few people hospitalized for it. And so to me, that's part of the balancing the risk. If you're somebody who has had anaphylactic reactions to many different things, then there may be a reason for pause. But if you're not somebody who has a history like that, then when you're weighing the risks and benefits, you're weighing the risk of 1 in 100,000 chance of an anaphylactic reaction, probably less if you've never had any sort of severe allergic reaction in the past, versus an illness that has already killed, I think last I saw was 1 in 826 Americans. So I think I think that's one of the things that's important to note is nothing goes without risk. I mean, a vaccine, of course, there's some risk. So getting in a car has risk. And so I think, everything in life has some degree of risk. So we can't say there's zero risk with getting a vaccine. What we have to weigh it against is what is the risk of not getting the vaccine. And I think that's where the huge distinction is that if you're somebody who's had a frequent severe anaphylactic reactions, then there might be a reason not to get it. But if you're not in that category, then I think I would say that the risk benefit balance is in favor of getting the vaccine.
Okay. We had a New Jersey question, you answered that. We had a transplant question, you answered that. Here's another one. If you're on Kalydeco, does that affect how your body responds to the vaccine? Or should we take a break from taking Kalydeco a few days before the vaccine?
I cannot think of any plausible reason why this would have an effect.
Okay.
Right. Yeah. And I would make the argument, don't like these medications are so effective just for maintaining lung health that and overall health that I would not advocate for stopping them. Yeah. I don't think there's any good reason to think there's an interaction between the vaccine and those medications.
Got it. Okay. Do we know how long the vaccine remains 95% efficacy?
Yeah, I think we tried, to put some slides on that. We do not know. We do not know how that, is going to be. This is, that part of the questions that we do not know. For people that say what we do not know about the vaccine because it's too new, that's part of it. How long does it last? Do we need a booster? Does it, still last, even if you don't take a booster, to make, the infection more like, if you get it a second time, more like a mild cold compared to before? Those are all questions that unfortunately are unanswered. And the fact that, the vaccines, were developed quickly, those are questions that we cannot answer right now.
Okay.
Dan, do you want to add anything on this?
Yeah, well, I think one thing I would say is there was a recent paper that was published showing how long does immunity last after having COVID infection. And obviously it's early days in COVID, but they were showing that there's pretty good evidence of persistent immunity at the 8-month mark, with the presumption that it would go even longer. Now, part of it then it gets confusing because then you see news reports about somebody who gets reinfected, and it's like, well, once you're dealing with the stats that tens of millions of people in the world have had a COVID infection, yeah, there are going to be some outliers who get reinfected, but that doesn't mean it's common, and it makes front page news when that one case happens, whereas if you were doing front page news for everybody who died of COVID, there'd be 4,000 front page stories from yesterday. So I think it's tough because the media likes to grab onto the one sensational case, but that one sensational case might not be representative. But so anyways, so there's a little tangent there. But with respect to the vaccine, there's I don't think there's a good reason to think that it would last less than immunity after COVID infection, and there's even some thought that it might even last longer given how it generates immunity. But the big caveat to that also gets to what Dr. Hodge referred to earlier, which is when the virus is mutating, there's this strain that was first identified in the UK, which thankfully the information we have so far looks like the vaccine will still work against that strain. The question is, could there be other mutations, other strains that develop that then resist the vaccine? Potentially, but one thing that's really good about a messenger RNA vaccine is it's really easy to reconfigure the vaccine to cover a new strain, which means people would have to get vaccinated again to cover the new one. But that's some of the nuances in terms of what might happen down the road if the vaccine mutated, or if the virus mutated in a way to evade the vaccine.
Okay. Next question, if you're able to remain in quarantine, do you anticipate any value in waiting for future vaccines? Is there any
That goes back
benefit?
to, I think
Like,
that
would
goes,
future ones be better? Is that the question, I guess?
Yeah, I mean, is there any benefit for future vaccines over the ones that are already approved?
well, I mean, throughout, basically the vaccine history, there have been improvements as, things go along, either in the effectiveness, in the manufacturing, in the stability, in the long term. So potentially, yes, but that's theoretical. And the question is how practical and how risky is it to wait for a new, vaccine from that perspective? So if you can say, I can stay in quarantine, I will be, in a bunker, I will never see anybody for another 2 years, and wait, to see what happens. Okay. I mean, but in the big picture of things, if you want to have some semblance of some things that you're doing, I think the current vaccines are very, very good. So it's difficult, how are you going to beat, the 95%, from our perspective. But, might there be, some improvements afterwards? Yeah, of course there will be, some improvement. We expect that. But for a first, hit, this was a pretty good.
Yeah.
I would say more than pretty good. I mean, that's the whole thing. If this were a 60% effectiveness, then I would say, yeah, maybe one of the next ones is going to come out better. It's going to be hard to top 95% effectiveness with the safety data we're seeing with these vaccines. So, yeah, so can we, again, it's one of those things, can we say with certainty, like maybe there's something that will have 99% effectiveness, but I think overall these vaccines are so effective that banking on the idea that something's going to beat something that's this good, it's a stretch. So I would not, and I not only would I not, I did not hold out. Like as soon as I was able to get a vaccine, I got one. So
yeah, and maybe they were referring to like side effects or safety, something like that.
Yeah, and I think with that, I think the people who have severe allergic reactions often will have severe allergic reactions to multiple different things. So I would be surprised if the allergic reactions are less. I mean, just like we were saying, where the allergic reactions to the COVID vaccine are similar to the flu vaccine. I think with any vaccine, you're going to see some small rate of severe adverse effects. And but I think it's that the fact that it's really infrequent and unlikely, and that you're getting in a medical setting where you're being monitored closely and getting treated appropriately is the key.
Got it.
And then the other thing, how feasible is it to completely, bunker yourself down for a long, long, long time from our perspective?
Here's an interesting question. They're all interesting. Are there any ongoing studies on whether CF patients may have some protective feature that keeps them from getting COVID or getting severe COVID?
That's a very, very interesting question. I don't know if you want to take the crack at this, or you want me to say some things?
I haven't seen data on this. I would say, my best first impression is that CF patients have had a long time practicing what everybody's been asked to do in the past year that was new to everybody else. I've had many people in clinic kind of chuckle about the idea that like 6 feet apart, what's the big deal with that? Like we've been doing that forever.
Yeah.
And so I think part of it is CF patients have really good practice of being really good at infection control maneuvers. So that's been very helpful. And then, yeah, other speculation is age has helped decrease the degree of severe illness. I think the fact that CFTR modulators have come out and have improved people's lung health has made a difference. Even the fact that we see obesity as a risk factor, and it's not that, I mean, there are some people with CF who have obesity, but it's a very small percentage of people with CF. So because one thing about COVID that's strange is that it seems to actually attack blood vessels. So that's why a lot of these cardiac risk factors, diabetes, high blood pressure, prior heart attacks actually are a high risk factor for a respiratory illness, which is not common for most respiratory illnesses. And I think it's because of how COVID is unique in the way it goes after blood vessels. So I think that's a factor too, is that some of those cardiovascular, and that's why older people are affected so much worse, is that cardiovascular injuries develop over time. So I think it's just that those concurrent medical problems don't exist as much in people with CF. I think a bunch of those factors play a role as well.
Okay. We're coming up on 8 o'clock, so I don't know where you guys.
I'm okay to continue on my side. I don't know about that, but I can stay on, to answer more questions.
Maybe just a few more, and then we'll. Okay, I guess this question kind of goes with if the CF centers are going to administer, which you don't know, but will there be drive-through or safer ways to get vaccines so we don't have to go to public places and put ourselves at risk of exposure? So I'm assuming that is if you guys say the CF centers are you're gonna administer them in clinic, do you see us coming into the clinic and getting them, or doing drive-bys, or?
The logistic of doing drive-bys would be difficult because I know from us having the vaccine, they want, observation for about 15 minutes. So how are you doing, drive-through for 15 minutes, observation, unless at some point they collect enough data that they say that's not needed. So drive-through might be difficult. But what I can tell you is that's why we were thinking that it might be large places, like what Dan described in New Jersey, like our experience was. It wasn't, given in our clinics or in crowded places. It was like social distance, large, area where you go get your vaccine, you're observed for a little bit of, time, being distanced from other people, and then you go out. So that might be the case instead of being in the clinic. But I suspect that, drive-through the way that the protocol is for most places right now, it's not going to be a likely, thing. Now, they might come up, in another, month or two, they might have given, 50 million, doses. And they found out that the anaphylaxis is so rare that maybe they will say, okay, drive-through is okay. My kids had a drive-through flu vaccine, basically what happened. They just went, got out of the car, signed the papers, they got it, and they got back in. But that might not be the case for this vaccine, at least yet at this stage.
Okay. When the vaccine becomes available, if we have the option of getting Moderna or Pfizer, any reason to get one over the other, or no, okay.
Anything to add on that, Don?
No, I
They
think
look so
the data are so similar between the two that I think it's just get whichever one you can.
Yeah.
I think that question becomes more pointed if one of the other companies comes out with the data and it's 75% effective, but you can get it. So do you get that one or not? I still think I would lean on the side of, hey, if that's the one you can get the vaccine, and if you feel like, hey, I can get a better vaccine later, then do that. So that question might become more relevant as more companies have data. But if they're all looking at 95%, then I say just,
or even 90.
Yeah,
you're not in the same population, so you might have some differences. Now the one that like for example the Chinese one from Brazil that talks about 50, probably 50, 95 is different. But even 90 or 85 to 95 is very, very similar.
Right. Yeah. If that 50% vaccine was available, I would say hold out for the 95%.
Okay. After getting the second dose, when does your coverage reach its full capacity?
Yeah, I mean those curves that Dr. Hodge was showing earlier in the slides, it actually was even for after the first dose, the curve started to separate in the 10 to 14 day range. So that's when we're first seeing some evidence of response. And also, the reality is you're probably starting to get some protection even before then, because you figure that's when people are being diagnosed, and people are being diagnosed were exposed a few days before that. So the idea is like that the full coverage is probably once you're getting to a couple weeks after the second dose is probably when you're at your maximum amount of coverage, but you're starting to see some benefit even within the first 2 weeks. But again, that's where it comes down to the idea where, since we don't know, can people asymptomatically spread? And like I said before, I would be really surprised if they can, but we don't know that for sure. So that's why the recommendations are still wear masks, do the social distancing, be as safe as you can until larger swaths of the population have also been vaccinated.
That's also, where the idea of giving one shot to everybody and delaying the second shot has come from, is because, the one shot seems to have significant effectiveness. So, they're trying to hedge the bets. Is it, better to get more people, the one shot than, to just give much fewer people the second, shot and delay the second shot? Even if you go like 4 or 5 weeks, you still get a benefit.
Okay. All right. We'll do 2 more here. Should people who have had COVID get the vaccine?
Tough question. So the answer to this is, if you think the COVID infection as a first vaccine, and it's, quite a few months, old, it probably makes sense, to at some point, consider getting a booster. There might be also a reason that the vaccine might be more effective than COVID itself. So, is it the same, risk than if you've never had it? Absolutely, not. It's probably, much less important for somebody like you. And it's also the distance from the time that you had the event. Like if you're within, a few weeks, you probably won't get, as much benefit from that. But if it's, something that you got in the first, wave, like at, basically, in March, and, right now you're having a vaccine, I would probably get it. I would recommend that you do it. I don't know if you have different, thoughts on that, Dan.
Yeah, I think, the recommendations I've seen have been wait at least 3 months after you had COVID, or at least 3 months since you recovered.
Yeah.
And then, but I think it still makes sense to get the vaccine.
Okay. And the last one is the CF Foundation, or do you know if the CF Foundation is actively lobbying for the vaccine?
100%. The CF Foundation has one of the strongest, lobbying, efforts. They do it all the time. They are pushing, for it. They're making sure patients with CF are, everywhere. I'm sure they're going to, talk about that tomorrow. They have another, national, panel about this. So yes, they are. No question about it.
Okay. Yeah, and I just wanted to mention that too. Yeah, for those who want to tune in tomorrow night. Do you know what time that is? Is that 7?
I think it's 7 p.m. again.
7 p.m. The National CF Foundation is having informational webinar on the COVID vaccine, so that would be interesting to tune into. All right, gentlemen, thank you so much for your time and answering all this. Was very insightful and great information, and we at Take a Breather really appreciate you taking the time to answer these questions and clearing things up for some people. And it was very informational, and we appreciate that. Also, again, want to thank our sponsors who helped us bring this webinar to you: Vertex, Viatris, Gilead Sciences, Nestle Health Sciences, and Optum Specialty Pharmacy. Thank you very much. And for everybody that tuned in, I hope it was as informative as I thought it was. And everybody, hopefully you have a good night and stay safe.
And actually, can I add, Matt, thank you for arranging this. And also one thing that really struck me about this is one of the reasons I love taking care of people with CF is just how on top of things people are. That when we had a gap, that we had missed the New Jersey information, that people are right there with that information. And I love how invested in health people with CF are, and that and I'm always picking up stuff from CF patients. So it's great to work with this group of people.
Yeah, it's
one thing to add.
One big family.
Yeah. If there's questions that are unanswered, I'm happy, if you send them, to me to send, some, answers or something like that behind that. Okay.
Yeah. And if you don't have Dr. Hodges or Dr. Hadjiliadis or Dr. Dorgan's email, you can always funnel them through us and we can forward them over to them.
Yep.
All right. Thank you, gentlemen. We appreciate it. And I'll see you in clinic.
Take care, guys.
Have a good night, everybody.
All right. Thanks, guys. Have a good night, everybody, and stay safe.
Bye. You too. Bye.